The third wave of COVID-19 continues to batter most parts of the African continent. The World Health Organization is already predicting the likelihood of an impending fourth wave. There has been a dramatic surge of infections across several countries on the continent, with the number of deaths now increasing by almost 40% in the past week alone. This while the continent lags behind with vaccination. So why are African countries dismally failing in the fight against this deadly pandemic? Tonight, we have gathered 4 medical experts from across the continent for a discussion on this. Dr. Hanelisa Tete joins me from Accra in Ghana. Dr. Ejike Oji is in Abuja, Nigeria, and Professor Solwayo Ngwenya will join us in a moment from Harare, that's just around the corner here, neighboring Zimbabwe, as well as Dr. Vivek Solanki from Bulawayo, also in Zimbabwe. Good evening to you all, and thank you very much for your time tonight on In Focus.
Good evening. Good evening. Thank you for having us.
I'll begin with you, Dr. Ejike. In South Africa, there's been a lot of reaction to the question of the slow rollout of the vaccine, but also to the fact that we are now seeing more restrictions now as the country enters a third wave. And some are saying, well, 12 months ago, we would have said this is a crisis. But after 12 months, it's no longer a crisis, but it is a failure by government to be properly prepared in terms of early detection, but also, most importantly, in terms of ensuring that a majority of citizens are vaccinated. From a medical point of view, not necessarily from the politics that come with it, from a medical point of view, what is your feeling on that particular claim? Is that claim valid?
I'm sorry, I lost you a little bit. I think there was a glitch. I didn't quite hear what you said. If you could repeat the question, please.
I'm saying 12 months ago, we would have said this is a crisis. But the fact that most countries on the continent are going through a fourth wave 12 months later, it's no longer a crisis, but it's a failure of governments. What do you say to that statement? Is there validity to it?
Yes, I think the African continent had a lag period to be able to respond to this disease better than what has happened across, even though some countries have done better than the others. Why I say so, that it started from China, went to Europe, America, before it came to Africa. So there were a lot of lessons learned before the final, I would say, invasion of Africa by this virus. And I felt that a lot of things could have been put in place. I know that most African countries are struggling with financing. A lot of countries did forward purchasing of the vaccines even before they were completely proven to be going to be effective. So they made some adequate arrangements to get vaccines. The other thing is that across Africa, I don't think we did a proper public education and community engagement on this issue to make sure that the citizens of Africa know the importance of this disease. Because if you look at the disease, we know the biology, even though it's a novel virus, but we have some sense of the biology. We also have a very good sense of the transmission dynamics. So the only thing humans have to do is the behavioral response to the disease. And if you look at the waves and it goes up and comes down, it's all tied to the behavioral aspects of humans towards the disease. So, and one vaccine that would probably have stopped the disease continue to spread is proper public education and community engagement on the issue. If you ask me, that is one area that we have lacked. In terms of resources, people don't have money, can't really do much about it. But I think also strategic purchases as we speak in issues of this kind of thing would have made sure that some money also was made available, even though the pandemic has actually caused a lot of untold destruction of financial plans.
Dr. Vivek, I mean, it's not the first time that we deal with outbreaks on the African continent. Based on lessons learned from previous outbreaks, has this played out in the way that it should have played out?
In fact, the reality is that we have done better. On the contrary, from what people are saying, that there is dismay and problems in Africa, we have responded well. This virus basically came to us much later. From China, it spread to Europe, went to Northern America, and then it came to Africa. So we were anticipating, and we were getting prepared of the onslaught that was coming our way. And if you look at the number of cases throughout African countries, and I've got numbers here from the SADC region, total number of cases in Zimbabwe of COVID cases, 47,000. In Zambia, 143,000. South Africa, of course, was faring the worst with 1.9 million people. Mozambique with 74,000 cases. I mean, I think under the circumstances, with the limited resources and facilities available, we have done extremely well.
We have now.
Yeah,
what is the challenge that we have now?
So the challenge now is to get to herd immunity by vaccinating as many people in the population as possible. And now we find that even if we have the money, and Zimbabwe has put money aside, I speak on behalf of Zimbabwe, that's where I'm from, we have put money aside, but you are on the waiting list, right? Even if you pay for your vaccines and you are not the priority, the other richer countries have paid in advance, are putting geopolitical pressure on the producers of vaccines. So we are getting the leftovers. And that is why there's a lag in Africa of getting the vaccines. And one has to be cognizant of this.
5 million people now on the continent or so, maybe slightly more now, as the Delta variant begins to dominate, particularly if you're talking here in South Africa. Now, looking at those numbers and looking at the response, as you are saying, do we have the capacity to respond to variants, right? There are some who are saying, for example, the 501Y.V2 variant is more scary than the B117 or the B1617.2 variant. Are we completely capacitated to be able to respond to these variants and their level of immunity to the vaccines?
We are close to that. We are not at capacity, but under the circumstances, we are doing pretty well because we have learned our lessons from the previous two waves that we have received. The first one, of course, all of us were a bit concerned. We were anxious. We were not sure what treatments to use, what was going to work, what wasn't going to work. We were watching the Europeans, we were watching the Americans to see what the outcomes were. We learned from that, and we implemented that. In fact, I got to commend our particular government in Zimbabwe, where they took proactive action. They did public-private partnerships early on, started training the healthcare workers in how to deal with the COVID situation, how to treat the patients, how to take the precautions, how to wear the PPEs and masks correctly. Public information dissemination was broadcast all over. And communities came together and started doing community responses, getting PPEs together, donating, preparing oxygen cylinders. And this has been going on throughout the SADC region, if you see, the response of the public and the governments, respective governments, whether it's Mozambique, Zimbabwe, South Africa, Zambia, Malawi, it has been tremendous. And so I think that endeavor is continuing. I'm a frontline worker. I'm treating COVID patients at my hospital. And we are there in the front, and we see the support we get from government and community and the health sector around. I think that momentum has to continue, and appropriate lockdowns. We can't just do nationwide lockdowns.
Yeah.
I think what we have to do is what we are doing at the moment is hotspot lockdowns, dissemination of more information, sending more resources to those areas where there's hotspots, and try and curtailing the numbers.
I want to come back to you on that appropriate lockdowns. Many are saying the restrictions that we're currently putting in place are not effective. But Dr. Annalisa Teta, I want to bring you in now to give me your view on the statements that have been made by some experts who say we won't be able to stop a fourth wave. You have to have a high level of vaccination to stop it, 70% to 80%. Does that mean we now need to sit back and accept the fact that, yes, indeed, a fourth wave is coming? Or is there something that we can do about it?
Well, I don't think that it's entirely true to say that we won't be able to manage a fourth wave. I mean, in instances, we've done very well, but I think that we could have done better in certain instances as well. Our leaders have done what they could, but I think that I'll talk not on the leaders, but on us as well as citizens. I noticed that education was a big challenge, and people were educated, but now whether or not they were going to believe what they were told was another issue. There was an advantage and a disadvantage to the fact that we, Africa as a continent, received or were infected later. So we're able to pick on the solutions and the management from the countries that suffered it, and we're able to leverage on them, build upon them, and use them in our countries, in Ghana. But I think that our challenge was the fact that we saw a lot of people dying in the developed countries, and we didn't see that here. So in most African countries, they kind of relaxed and believed that it wasn't that much of a black disease, and that's kind of affected how much we respond or how well we responded to it. I think that if we strengthen the precautions that we have already put in place, we should be able to manage it. Also, a lot of education needs to be done because we are set in our ways and we have a lot of cultural beliefs and systems that we're rooted in. It makes it difficult for people to accept vaccination, and we need to do a lot of education, as Dr. Ejike mentioned. So it's not entirely true to say that we won't be able to manage a fourth wave. I think that a lot is being done. In Ghana, for instance, before a traveler comes inside the country, there's a testing done at the airports. There's testing done at all the borders. And so we're able to arrest all the cases that are being brought into the country. They are isolated and then they are managed before they come into the community. Another thing that has also helped us is contact tracing. So if somebody tests positive, over a period of 2 weeks, you are asked to bring everybody you have been in contact with, and then we test those people as well. And I think that's what has kept our numbers and our recovery rates at about 97%. And we've had 795 deaths. So I think that, yes, a lot has been done, but then again, more can be done. So it's not entirely true to say we won't be able to manage a fourth wave.
Dr. Ejike, how do we decide which measures to introduce? I mean, from a doctor's perspective, if you're dealing with patients who are, for example, showing signs of the Delta variant, how do you decide what measure to put in place, particularly considering that you would want to minimize hospitalization?
Yes, the thing is that if you look at the disease, it has three, should I say, categorizations. One is asymptomatic, the other one is moderate, and then severe to critical. So I think that has always guided practitioners on how to manage. Initially, when the disease came, almost everybody was managed in isolation units. And that's one area I think the Nigerian government did tremendously well to start building isolation centers across the country, so that a lot of hospitalization was done, because the lessons learned from Europe and America was the fact that the disease overwhelmed health systems. So their redundancy was completely taken over very, very quickly. So, and that guided what was done in Nigeria in terms of making sure we built redundancy, built a lot of isolation centers into capacity. So initially, like I said, everybody was isolated. But as the disease progressed, and then also the government looked at the enormous resources that was being done. So there was some level of categorizations for some people who will be able to do self-isolation at home. So protocols were introduced to make sure that those people isolated at home and took care of themselves. The only problem that normally comes is when somebody is moderately ill and people can quickly progress to severe to critical. And that was the issue of oxygen resources. We, at the second wave, we had that initial problem that the government moved quickly to improve oxygen supply. So for those ones who are critically ill, they still need hospitalization. And then one of the most important ingredients in the management is the oxygen resources. You can see what happened in India. And then remember that this particular variant is so fast, so it infects so many people per unit time. So it has that tendency to overwhelm the health systems. So for me, I think those are the areas we should pay attention to, and then make sure. Luckily, I think they still say that the current vaccination that we're using can still stop the Delta variant, even though the vaccination process in Africa is slow.
Yeah. Do you think we made a mistake, particularly on the AstraZeneca vaccine, and that we should have actually acquired it more, even with that scare a little bit earlier on, and some experts saying it was less efficient against the new variants that were beginning to emerge?
I wouldn't say anybody made any mistake because people had to make a decision at that time. No decision at all would have even been worse than making the decision that African continents, especially Nigeria, made. Even the 2 million vaccines that were acquired for Nigeria, it wasn't completely, given out because there's a lot of vaccine hesitancy. I think my sister from Ghana did mention the fact that there was a lot of conspiracy theories. People will say, we're not dying the way they are dying in Europe. Why should we be being disturbed here? So that made also a lot of people didn't taking the vaccine seriously. Yeah. Even if we had acquired twice the amount of vaccines the government was able to bring in, I can tell you we wouldn't have been able to completely offload the vaccines. And that's why for us to prevent any catastrophic events, this is where I feel that we have to up our game in terms of public education.
For the break, we're discussing broadly the question of AstraZeneca, but also, Dr. Vivek, you brought up the question of restrictions. Now, in Zimbabwe, of course, business hours have been restricted, but not only that, there's some restrictions, for example, on resorts and as well as farming towns. Many are saying these restrictions have not been effective. Certainly, they feel that they are hitting hard on the economies of many families who actually need to be out there, especially the informal traders. What's your feeling?
So this is, yes, it's a huge challenge, right? How do we look after the informal sector? The people that are on daily wages, who have to hustle every day to make a living and put food on the table. That's why we are focused in Zimbabwe on hotspot lockdowns. We have not gone a nationwide lockdown. We have said, all right, let's look at our border towns. Let's look at some of the bigger centers and the near border cities and towns and lock those down. Educate those people, provide resources to them and supplement them, all right? So it's very difficult, and we went through this hardship in the last wave in December and January, where the entire nation was on a very strict lockdown, and the economy did suffer. People did suffer. But the controls were necessary, and it was successful, right? The dissemination of information was there. The understanding of the public was there. People were wearing masks and socially distancing and that. But right now, I think what we are finding is fatigue, right? Where people are tired of these lockdowns. People are tired of the restrictions. They're unable to plan. They're unable to send their children to school. They're not coping at home. They're not functioning. They're not earning enough income. So this is becoming a huge problem. It's a major challenge. Unlike some other Western countries where they have a good social infrastructure and support from social services, and that this is a challenge for us to deal with.
African countries, many say, have failed to monitor strict, or rather to put in place strict monitoring of travelers, and hence we are seeing a lot of mobility when it comes to the virus of the continent.
So we have a lot of transient populations, right? We have our migrant workers. We have porous borders. So it is difficult because if a man has to survive, he has to go and cross the border. He has to go and find jobs on farms, in the mines, in other informal sectors and things like that. And they have to move around because without that, they cannot survive. So this is where our problems are, is that we are getting cross-border infection transmissions. Very few within the country, but it's the ones that are coming. So if you look at our border areas with Zambia, Kariba, Hurungwe, Koroe, if you look at Beitbridge, Masingo, Mutare, these are our hotspots, right, of where most of the cases are taking place. And then, of course, within the internal travel, it's disseminating and spreading. However, despite of that, still, the numbers are contained, and they are still well below what it was during the second wave. We are learning, whether it be slow or not, we are learning, and it's a major learning curve, how to contain it, how to control it, how to treat it. We now have protocols in place, how to manage such patients, whether they are treated at home. We now have outpatient treatment centers so that we do not congest all the hospitals. And this is working. We are monitoring. We are informing the patients. They are aware where to go, what medication to take. Our Ministry of Health has set out protocols to follow for the various stages of the infection. And it's working fairly well.
Yeah. Many say we opted for that. We opted for the outpatient approach because we lacked, for example, capacity to build hospitals. In China, for example, in Wuhan, at the time of the initial outbreak, they were able to put up and set up a hospital in a week. And many say, well, African countries have got no capacity to do that.
Well, that all depends on the resources, right? China is a massive country. It's a rich country, second richest country in the world. They have the resources, they have the money, they have the know-how. We are lacking all these things in this part of the continent. To put up a hospital, we could put up a hospital in a week or 10 days or even a month, but you need the money for it. And that is where we have a problem. There is not enough infrastructural development and funding for such facilities. We have lagged behind in developing our health sectors because our focus has been on something else, developing other infrastructures, the mining industry and resource management and power supply and things like that. And the health sector has been on the back burner. We have had a very successful management of the non-communicable diseases, communicable diseases, vaccination programs outside of COVID, of course. So there's been many other successes, and I think that's when we became a bit laid back and said, well, systems are working. We are managing the HIV the epidemic that we've had. We've been managing the cholera outbreaks and the typhoid outbreaks and that. So it's okay, and then nobody paid focus to it.
Yeah.
Come COVID, I think it's been a wake-up call, not only for the people in Africa. I think it's been a wake-up call even in the Western economies, the prolific and the wealthy economies. It's been a major challenge for them. So under the circumstances, I think we should pat ourselves on our back and support our structures and our governments and the ministries of health and just move forward and surely carry on. And I think we will be able to handle the fourth wave even better than we've had the third wave or the second wave before that.
I'll come back to that wake-up call. Are we setting ourselves up for a rude awakening? Should indeed the variants mutate and escape the kind of vaccines that we have right now? But Dr. Annelies, let me bring you in here. Talking of supporting the structures that we have set up as the continent, in March, I think around the 6th of March, the COVAX facility welcomed 20 million vaccines to 20 countries. Not nearly enough compared to what we need to see here on the continent. Others saying we need to see close to 1 billion. Is it time to change tact as far as that approach is concerned, and maybe get other tactics, get the private sector involved in the procurement of vaccines and not centralize it to governments on the African continent?
Yeah, I think that would be necessary or that would be a laudable idea if there isn't vaccine shortage in itself. Right now, one of the major challenges is the vaccine shortage. Even if you have money, of course, the stronger and well-resourced countries are in a better position to get the vaccines. So it's like we are just at the receiving end. The underdeveloped and the developing countries are at the receiving end. And that's one of our challenges. But of course, most importantly, we need to involve the private sector as well. In my country, we've been supporting research. What I noticed with most African countries is that there isn't a lot of research support. So we don't see the value of research to be able to push money into research so that we as Africans can also be able to produce our own vaccines, because we can't rely on just one source. And that's where we should be looking at, building more research centers, supporting it so that we'll be able to make our own vaccines. We have a lot of scientists, but we need to empower them and support them financially. Yes, the private sector needs to be engaged because it will be a very good source of receiving or getting more vaccines as well.
And do we have any ideas as far as new variants that will escape immunity? And are we working towards that?
Well, I think that just like I mentioned, our research is a bit lacking. And as for the variants, they keep coming because they will keep coming because people keep moving. There's a lot of mutation. Yes, they'll keep coming. As to which of them would survive, would have to wait and then find out. So yes, there'll be more variants until we are actually really done with the disease. There'll keep being variants. And I think that the only thing we can do now is to help empower the scientists and the researchers so that they are able to be well equipped to be able to fight this vaccine.
Yeah. How have you dealt with,
to fight the virus?
How have you dealt with vaccine hesitance as we are continuing to talk with the issue of vaccines, right? There are suggestions, for example, that the phasing in approach is something that is part of what's delaying Africa from getting the larger population vaccinated. Some doctors in South Africa have suggested that vaccinate all who want to be vaccinated, as opposed to taking the staggered approach that we have seen many countries following. How is Ghana approaching that?
So for Ghana, we had our first supply I think in February, since 3rd February, we had about 600,000 doses. And then we vaccinated people. And then we had the second batch in May. That was the 7th of May. And we had about 300,000. The deployment of the Democratic Republic of Congo's vaccines. Yes, we have that. So currently we've vaccinated about 800,000 people. The challenge with us is the inability to achieve the herd immunity. So yes, we are vaccinating people where the second batch was actually given to those who had received the first vaccine. So if you didn't receive the first vaccine, then this second batch you went part. And that poses as a challenge because it's difficult to maintain or to get to herd immunity. And if you're unable to do that, then the population at risk keeps growing and keeps increasing. So that has been a challenge for us. Our government has promised that they are going to get more vaccines for us. But like I said, we don't have the resources to make our own vaccine. So we still have to rely on the WHO distribution, rely on developed countries to be able to send some vaccines to us when they are ready.
Yeah. Dr. Ejeke, Reuters reporting that Nigeria is now adding South Africa to its red list of countries for which there are stringent restrictions for arriving passengers. How does Nigeria get to that decision so quickly? I mean, there's been, for example, many calling here in South Africa for South Africa to limit the travelers coming, for example, from India or those who in their route have traveled to India. It seems that Nigeria has been able to respond to that quite quickly and put South Africa on that red list.
Yes, one of the key things I would say that has happened to the Nigerian response to the pandemic is the nimbleness of the government in responding after the initial, should I say, slight delay in closing down our borders, but we'll close it down eventually. And I think that has made put Nigeria on notice that the sheer size of our population, if we get it wrong, then we'll be in trouble. So the government has been very nimble. Yes, travelers coming from India, Turkey, and I think one South American country can come to Nigeria. If they come, Nigerians, particularly coming from there, have to be quarantined in an institution. It's not a matter of allowing them to go do it by themselves. The government quarantines them in an institution. And that's had actually helped. I'm sure that's what they are also sending in a good way to South Africa. And then the other thing, talking a little bit about the response totally about this disease. In Nigeria, we had just about 4 PCR centers in the country. As we speak, we have more than 40 across the country. And then even the public-private partnership, the pattern of trusting behavior and goodwill the government developed. In fact, I could tell you that most of the isolation centers were through private sector efforts. Like in Abuja here, the biggest isolation center that was built within a few months was equipped and then put in place by the private sector. In Abuja here, the private sector also was able to build and donate a comprehensive modern PCR lab to the city of Abuja. So the response and learning lengths are so enormous. So in terms of the trying to, and that means the NCDC is very well and alert to its responsibility, having their biological vigilance, making sure that they are studying what's going on in other parts of the country and protect Nigeria from getting into that sort of problem. So I think this is one key area. There's a lot of PPP, public-private partnership, Not just that, even the private sector, bringing in money, donating PPEs, and then making sure they understood it, that we are in one ecosystem. We can't leave it for government. Otherwise, our businesses will also die. So they stepped up, and that is also continuing. There's one, this thing they call COVID, which is a private sector initiative. The major big private sectors in the country put in money in that. So it's been a very wonderful experience in terms of learning. And then what we are looking forward to, like you keep mentioning about the fourth wave. Nigeria will only have had 2 waves. We haven't had a third wave, not talking about a fourth.
Yeah.
We're not saying that it won't come. But the important thing here is Nigeria is actually ready. Almost every week, except recently, the presidential task force was up there informing Nigerians about what is going on and then monitoring when there will be a lockdown. In fact, when the second wave came, and then thereafter, and when the Delta variant was making its distance around, Nigeria imposed a curfew, a night curfew across the country. As we speak, even the level 12 officers and below in ministries, public distance are not still coming to. These are just measures the government is taking to make sure they reduce the number of people in one particular space, so that transmission will not be so high. And I also want to say this for Africa. Africa has been particularly lucky too in terms of there's no scientific basis, but at least there is what I would say anecdotal evidence that why we do not also have all those kinds of severe disease and multiple deaths like in other parts of the world. It is because of our youthful population. At least for once, I feel that the youthfulness of an African population has given some level of immunity. Not that they won't get the disease, but they won't succumb and die to it, even though they can transmit. Like in a place like Nigeria, we have 70% of our population is under the age of 30. So the issue of getting disease and dying from it is very, very slim. So if we look at Nigeria, the real population that is at risk, if we really measure it, is just about 10 to 12 million.
Right.
So, but the important thing is that the lessons learned have been properly applied by governments, and that's why we're so excited with what our government is doing here in the country.
For the break, I mentioned, Dr. Vivek, that according to a recent notice, the Medicines Control Authority of Zimbabwe has allowed the use of ivermectin in the treatment of COVID-19. What is the health industry there saying? What have they found as far as this treatment is concerned?
So initially, the use of ivermectin became very political. It was very confusing. There wasn't enough scientific evidence. The evidence that was available was coming from some small countries. But the momentum was going. A lot of the physicians here were fighting for it, the use of it and its effectiveness. And over time, I think the government and the private sector and the doctors came together with a common solution to say, let's give it a try. Let's make sure we document everything. Let's see how it works. So most doctors that I'm aware of in Zimbabwe today, we all use ivermectin, either whether it's for prevention, whether it's for treatment, for prophylaxis, we are using it, and we are using it successfully. We see the results. As I've said before, I'm one of the frontline doctors. I use it as one of my mainstay of treatment, and it's helping our patients. Our mortality rates are down to less than 1.3%. And I think one of the main reasons because we are using ivermectin.
Now, there was, of course, as you mentioned, this debate coming from some parts of the world around, for example, the question of dosing and how that dosing will be determined, because this was informally used, particularly used in animals. So one would not have controls and know exactly how much dosing would be required in an instant where you have to use it on humans. How did you get around that?
So again, yes, that is what was part of the reason why there was so much confusion and resistance of using this, not knowing what dosages to use in it. However, in the past 6 months, numerous studies have been carried out all over the world, and there are even more studies being done. We know what dosage to use now. You know, the recommended doses are there, or how much to use, when to use it. With it for children, is per kilogram. We've worked it out, it's per kilogram, what to give it, and it is working. And so we are following that. And more research, including in Zimbabwe, is being carried out on the use of ivermectin. and to monitor its side effects and effectiveness and efficacy against the COVID virus.
Yeah. Dr. Ejike, I see you're also nodding. Is it the same discovery in Nigeria?
Yes, ivermectin was introduced just like he said. Initially, there were discordant tones. Some physicians said they will use it, some didn't use it. But after some time, I would say it was like a person-led initiative because there wasn't enough pharmacopoeia in terms of double-blind, should I say, controlled studies, randomized controlled studies that gave very wonderful results to say yes. But then, anecdotally, people, when they were using the drug, they saw some effectiveness. And then a lot of people were even using it for prophylaxis. And then because if you look at should I say, the side effects that could come from the drugs, it was quite low. So a lot of people say, for whatever it is, let's use it. I won't lose anything, but I might lose something if I don't use it. And that encouraged a lot of people. In fact, a lot of people on their own decided to go into the pharmacy shop to buy it. At the time, the prices in Nigeria went through the roof because everybody was looking for ivermectin. Like he said, a lot of research is still being done, and I'm sure in coming months, some of those results will be made available to the public, and then there will be a scientific basis for using the drug. But for now, people do use it.
Dr. Vivek, I'll come back to you then again on that question of the wake-up call. Are we going to get a rude awakening? Yes, we're saying the continent has done well due to our youthful population, due to some, of course, of the medical measures we've put in place. Our experience, for example, in dealing with outbreaks on the continent, our experience in dealing with HIV/AIDS on the continent and testing and so on and so forth. But are we likely to get a rude awakening here of new variants that we have not been ready and prepared for coming through on the African continent? For example, we don't want to compare countries, but seeing the kind of surge that we saw in India.
The new variants and mutations are inevitable. They'll be coming and they'll keep coming. This virus is here to stay for a few more years to come. The important thing is that we are learning all the time. If you look at this outbreak from 18 months ago to where we are today, we know a lot more on how to deal with it, how to treat it, how to try and contain it. What we have to focus is on improving our infrastructure, health delivery services, supply of vaccines, adequate supplies of vaccines so that we can distribute them all over, and disseminate information and educate the public so that they don't panic. You know, the fourth waves will come, fifth waves will come, sixth waves will come. This is going to keep coming and going. We are not unique. The rest of the world is going through the same thing as well. And I think we should face up to the challenge. I don't think it will take us by surprise because the learning curve is there and we are learning and we are listening and we are watching and we are treating.
Dr. Annalise, let's talk about that distribution. I believe Ghana using technology now to deliver COVID-19 vaccines, particularly to remote rural areas of the country.
Yes. We're using the drone to do delivery. And I think that it has helped because initially waiting for the ambulance, waiting for cars to do the distribution, it took time. But then now using drones has really helped to get to remote areas where initially we couldn't get to. So it's really helped.
How long should Africans wait before they can also see their countries opening up and gatherings beginning to happen? One speaker was making an example, for example, say Europe is now watching Euro in stadiums that are packed while we, of course, are battling a third wave and more people dying here on the continent.
So I think that because we haven't been able to achieve herd immunity, we haven't been able to vaccinate as many people as possible, the fear of another wave is still there. We can't be complacent and think that because just a few people have been vaccinated or because just we've recorded less number of deaths than in other countries, that means that we can do exactly what they are doing. Also, we need to remember that the resources available to them is much more than the resources available to us in terms of fighting the disease. So they may be at a better position at handling the waves when they come in than as us. So there isn't really a specific time because we know how this is distributed. There's contact, and once people keep moving around and once we have to take care of the informal sector, we can't lock down everybody forever. But there still needs to be movement. We still need to enforce the precautionary measures, and that limits or reduces the risk of spread, but it doesn't completely eliminate it. So there isn't really a specific time that we can say that within this time, Africans should think that we'll be out of it. But we just need to keep hope alive, continue with our measures, continue what we're doing, contact tracing and treatment and management, enforcement of all the precautions that we put in place to ensure that at least we keep the numbers at their barest minimum. And then when we are vaccinated or we are vaccinated to levels that we think are safe, then we can say that now it's safe to move out there and do the things that the others are doing.
Doctors, I appreciate your time and your insightful information here tonight on In Focus. As always, thank you as well for your engagement and participating tonight.